now I would invite the other chairperson like Dr. Wonder or Dr. Sahani to introduce the next speakers.
Good evening, everybody. The next talk is by Professor Navin Nanda. He will be speaking on what is new in echocardiography for heart failure evaluation in HFpEF and HFrEF population. You all know Dr. Nanda is the father of echocardiography. Dr. Nanda, please, sir.
Thank you very much, Dr. Sahani. It's a great honor and pleasure for me to be participating in this very prestigious meeting, which has been organized by Dr. Girijanandan Mahapatra, who is really the pioneer of nuclear cardiology in India and a great organizer of many conferences and congresses. So I'll be speaking when it comes to heart failure ejection fraction in patients with normal LV ejection fraction. These are the guidelines which are recommended by the American Society of Echocardiography. Number one is to look at the average mitral E to E prime ratio more than 14, septal E prime velocity less than 7 centimeters per second, or lateral E prime velocity less than 10 centimeters per second. Number three, tricuspid regurgitation velocity greater than 2.8 meters per second, and large LA volume index greater than 34 mil per meter square. If more than 50% of these are positive, in other words, 3 out of 4 are positive, then you can diagnose the patient having diastolic dysfunction and diastolic heart failure. If less than 50% positive, then they have normal diastolic function. But you have an indeterminate set in between when only 50% of the patients are positive, and that is where the limitation of this guideline is. So there is some limitation of these guidelines in diagnosing LV function, heart failure with preserved ejection fraction. So what has happened in 2018, about 4 years ago, Yogesh Reddy from Mayo Clinic did a study. He looked at 100 patients, consecutive patients with unexplained dyspnea, and studied them by cardiac catheterization. And 39 of these patients were actually controls with non-cardiac dyspnea. And what he found statistically when he analyzed the results, he could come up with actually 6 criteria here: body mass index greater than 30 kilograms per meter square, 2 or more antihypertensive medicines, paroxysmal or persistent atrial fibrillation, age greater than 60 years. These are some of the clinical findings, and he added 2 echocardiographic findings: Doppler echocardiographic estimated pulmonary artery systolic pressure greater than 35 millimeters of mercury, and Doppler echocardiographic mitral E prime ratio greater than 9. And if a patient had 6 or more of these points positive, and here the points given to various criteria here, if there are 6 or more points, then the chances of that patient having heart failure with preserved ejection fraction was over 90%. So this was something which had just come in 4 years ago, and there was an editorial saying, at last, a properly validated diagnostic algorithm for heart failure with preserved ejection fraction. But there were some criticism for this study. First of all, some issues remained unaddressed. Distinct clinical phenotypes predisposing to heart failure with ejection fraction, like obesity, diabetes, and chronic kidney disease, were not addressed. Also, biomarker profile was not actually addressed in this criteria. Ultimately, it came up in his response that this score should be used for unexplained dyspnea in the absence of other causes of heart failure, for example, constricted pericarditis, cardiac amyloid, valvular heart disease, etc. Then actually next year, in 2019, Fiske et al. Came with their own criteria, and this was a consensus recommendation from the Heart Failure Association of the European Society of Cardiology. And what they did was, so they actually went on these criteria. They had 4 nodes here: functional, morphological, biomarker in sinus rhythm, and biomarker in atrial fibrillation. So in the functional, they looked actually all these same echocardiographic criteria that we use with the American Society of Echocardiographic guidelines, like septal lateral wall velocity, average E to E prime velocity, as well as the tricuspid regurgitation velocity. And then they also added global longitudinal strain less than 16%. So that was one other addition to the echocardiographic criteria. The morphological were the same, looking at large left atrium, as well as left ventricular mass index, as well as relative wall thickness were also used. And the biomarkers are given here actually. And then if 5 points or more of these, the major criteria went for 2 points, minor went for 1, and each node here had only actually, you could only use 1. If there were 3 points here, you could only use 2 points. And then if you find that any patient had 5 points or more, then you could really diagnose that patient as having heart failure with preserved ejection fraction. If they're 2 for 4 points, then they recommended diastolic stress testing, echocardiography. So ultimately what they said was to, first of all, go for clinical assessment in these patients compatible with heart failure with preserved ejection fraction, use the standard diagnostic tests like ECG, peptides, X-ray echocardiography, and then use their score. If it was high, then you have high heart failure with preserved ejection fraction. If it was low, then that's a non-cardiac dyspnea. And then if it was intermediate, then you go for diastolic stress testing, echocardiography. And then, of course, ultimately, once you confirm they have high heart failure with preserved ejection fraction, you investigate for specific etiology, for example, amyloidosis. So when it came to stress echo testing, they went for if the average mitral E to E prime velocity was 15 or more, tricuspid regurgitation velocity was 3.4 meters per second or more. If these two criteria were fulfilled, then the patient did have heart failure with preserved ejection fraction. On the other hand, if the criteria were not fulfilled, then you can go for right heart catheterization, invasive hemodynamics. So that is the recommendation they had. Now, the European, very recently, in this month, in February 2022, the European Association of Cardiovascular Imaging have come with their own criteria. Now, they have used practically all echocardiographic criteria alone, not using biomarkers or not using body weight and age, etc. So they found that if you look at the mitral E velocity over A velocity, E to A ratio greater than 2, then you definitely diagnose the patient having elevated filling pressure. It was less than that, normal filling pressure. And then if only 2 criteria, now these are the other criteria, if the mitral E to A was greater than 0.8 but less than 2, then you could go for these criteria, which was, again, mitral E to E prime ratio greater than 14, tricuspid regurgitation velocity greater than 2.8 meters per second, LA volume greater than 34 mils per meter squared. Then 2 or 3 criteria were positive, the patient had elevated filling pressure, and they were 2 or 3 criteria were negative, they're normal filling pressure. Now, what you do if only 2 criteria were available and one was positive and one was negative? Then what they suggested was a new criterion, also echocardiographic criterion, that was looking as LA, left atrial reservoir strain, by using speckle tracking echocardiography. And if that was less than 18%, the patient elevated filling pressure. If it was greater than 18%, patient had normal filling pressure. So they used here, this is the latest criteria, used only echocardiographic criteria, added these LA reservoir strain to that. Now, this is not new. I mean, in 1993, our group and Dr. Ortiz's group from Brazil, we published that if you look at this mitral E to A prime ratio here, for example, a very high E to prime ratio, then actually the survivor was very, very poor. On the other hand, if it was normal, survivor was actually survivor good. And then if there was the atrial component was larger than the initial component, in other words, A wave was greater than E wave, it was somewhere intermediate. So this is not new, but then they have resurrected some of these criteria published almost 30 years ago. When it comes to LA strain, we have a paper which we just published, a review paper. This year actually is 2022, not 2021. And they review, if you look at the review, LA strain, strain or reservoir strain is better than LV strain in diagnosing and predicting outcomes in left ventricular diastolic dysfunction, early stage heart failure. So LA strain may become abnormal even before you get the other criteria for LV diastolic dysfunction. So that was the important thing in terms of this. The other thing which has come up is actual lung ultrasound. When we use an echocardiogram, we avoid the lungs. Lungs are right there when we do an echocardiogram. But now we are saying that also look at the lungs. And if in the lungs, when you lung ultrasound, if you have B lines, that tells you that there is water in the lungs. That means there is pulmonary edema. And it is known that almost 60% of the patients with pulmonary edema, clinically you do not hear any RALs, you don't hear any wet sound at all. So you miss pulmonary edema. So the incidence, the prevalence of subpulmonary edema is quite high. And this lung ultrasound can become very, very useful. It's just when you look at the heart, go next door with your probe, and you can actually examine the lungs very clearly here. Not only that, if you look at this from Dr. Picano's work here from Italy, If you go for this movie here, at rest, you can see very few B lines. But when you stress a patient, that means when the pulmonary edema becomes more severe, you can see a large increase in the B lines. And also when you treat the patients, B lines also reduce in severity. So these are the new criteria that have come up is LA systolic strain by speckle tracking echocardiography, as well as usefulness of lung strain. Global longitudinal strain has also attained more greater importance. This very new study published this year, actually probably almost this month or last month, showing that if the strain is low in these patients, then the prognosis is poor. If the strain is high, the prognosis is very, very good. So what we have done actually, so this is a step to show you the LA tracing here. You go for a peak LA strain here, which is diastolic reservoir strain, and that has become very important. So now actually, so we have now quite a few criteria. Some have got echocardiography with other clinical criteria, other findings, some echocardiography with the biomarkers, and other echocardiography, and some of the more recent echocardiography are only looking at echocardiograms, and these are some of the new echocardiographic criteria that I have mentioned. So that's where we are in terms of in diagnosing heart failure with preserved ejection fraction. As far as the reduced ejection fraction, I think Dr. Monroe already pointed out that SGLT2 medications, they can treat over the whole great range of ejection fraction, except when the ejection fraction is greater than 60%, then those are not very valuable. So, but this does not diminish the importance of ejection fraction. It just tells you that some of the medications will work at different ejection fractions. Thank you very much for your kind attention. Didn't want to take more than 15 minutes here. Thank you again. Thank you, Dr. Grijanan Mahapatra, for inviting me, and Dr. Soni for chairing the session.